Moving on to NRG1, which is the new Regulin-1. This serves as a ligand for HER3 or HER4. You may have heard about HER2 in the context of breast cancer. And so HER3, HER4 are sort of, receptors in the same family. And NRG1 actually is a substrate that binds to these receptors and then prompts the heterodimerization, and then leads to, again, downstream signaling cascades for cell proliferation and survival. So with the NRG1, we see that NRG1 alterations frequency is not just in non-small cell lung cancer, but even in pancreatic, renal cell, ovarian. About 0.3% of non-small cell lung cancer cases are NRG1-driven. Again, RNA-based sequencing is helpful, and we see that NRG1 alterations are enriched in invasive mucinous lung adenocarcinoma, which is a specific histology within the adenocarcinoma context for lung cancer. So if we see that, we want to think about NRG1, but again, the overall frequency is about 0.2 to 0.3%. So really, really rare to find this. But again, if we don't test, we won't find it. So interesting advances in this particular subset of non-small cell lung cancer in the past year or two. This is, I guess I would say, one of the few oncogene drivers where we want to use first-line treatment as sort of the standard chemoimmunotherapy type of approach. But then at progression of the cancer in the second line or subsequent therapies, we want to use a more targeted therapy. And in this context is zenocutuzumab, which I'm going to talk about briefly. But this is, again, the national guidelines and was also recently approved in December of last year. And so this has been the major change in this particular subset of non-small cell lung cancer. So Zeno is essentially a bispecific sort of mechanism with NRG as well as binding to this HER2. It blocks the NRG1 binding the HER3 domain and then inhibits that cell proliferation and survival cycle, which can be caused by that NRG1 alteration. As we know that NRG1 exists in multiple tumor types, so this drug was tested in multiple different tumor types, and again, it did show good response in non-small cell lung cancer in the order of 35 to 40% in the most updated data set, actually. And then also in pancreatic ductal adenocarcinoma, which is the other tumor type where this was approved also with the NRG1 alteration. So as I mentioned, it was December of last year where it was approved both for non-small cell lung cancer and pancreatic adenocarcinoma. It is notably an IV treatment, unlike some of the oral drugs that we talked about and were talked about in the previous session. This is every 2 weeks, and it has to be given along with steroids and antihistamines because it has infusion-related reactions that have been seen. So the major side effects or safety concerns that we want to be aware of are infusion-related reactions or hypersensitivity. Want to measure the ejection fraction, so do an echocardiogram of the heart to measure the pumping and assess the function of the heart. ILD is one of the other side effects that we want to watch out for. But the most common ones are, diarrhea, musculoskeletal pain, fatigue, nausea, and the infusion-related reactions that we mentioned. So here are my key takeaways. MET exon 14 skipping non-small cell lung cancer, 1 to 2%. It is a targetable alteration. RNA-based NGS is important, as is for NTRK and NRG1. Capmatinib and tepotinib play an important role in treatment for MET exon 14 skipping. For NTRK fusion positive, we have 3 approved therapies: larotrectinib, entrectinib, and repotrectinib more recently. And then for NRG1, which is a very rare occurrence in non-small cell lung cancer in the order of 0.2 to 0.3%, but when present, responds to the zenocutuzumab, which is in second line and beyond setting. Thank you.